There's a lot involved with medication administration, so let's get started. And Franklin Delano Roosevelt said, when you come to the end of your rope, tie a knot and just hang on. So that's what we're going to do with this presentation. First thing, let's look at the prescriber's role. Prescriber can be anybody that can write a prescription. It could be a physician, nurse practitioner, or physician's assistants. Um, they are often referred to as licensed individual practitioners. Your orders can be either written by hand or electronic means. A lot of times you'll see computer physician order entry. They can be verbal or given by telephone, and Joint Commission says that verbal orders can only be used in emergency situations only. The physician really needs to write the order on the physician's order sheet. This is just to prevent errors. The use of abbreviations can cause errors, so you want to make sure you do not use the do not use abbreviations, and you guys have had access to that. You can look on the Joint Commission's website to look at those also. Each medication order needs to include these things: the patient's name, the date the order was written, the name of the medication, the dosage, the route the medication is to be given, what time to give the medication, the reason for the medication, and of course the prescriber's signature. And this is just a chart on the type of orders given in acute care facilities. You have your standard or your routine orders, or your standing orders, excuse me, or your routine orders. These are medications that are administered until the dosage is changed or another medication is prescribed. Some medications are given just one time, for a specific reason. For an example, if a patient is scheduled to have an MRI, they may be claustrophobic. So the physician will write for a one-time order of a sedative to give to the patient to help the patient get through that procedure. Your now orders are medications that need to be given within 90 minutes of the time that the order was written. It needs to be given right away, but not immediately. PRN is given when the patient requires it. For an example, pain medication. Pain medication as needed. So this is something that the patient would actually have to request. Your stat medications, these are what medications that are given typically in emergencies, um, given absolutely right now, immediately. And of course, your prescriptions, those are medications that patients take outside of the hospital. They are required to get those filled at an outside pharmacy. So, looking at the pharmacist role, they are the ones that actually prepare and distribute the medication. You have some distribution systems, unit dose or automatic medication dispensing systems, kind of like our med dispense that we have in the lab. These are areas for stocking and dispensing the medications. Some facilities use Pyxis, some facilities use MedDispense, some facilities use Omnicell. Don't get too hung up on the individual dispensing medication. Just be familiar with that process. The nurse's role, your role, is to assess the patient's ability to either self-administer the medication, determine whether the patient should receive the medication, administer the medication correctly, and very closely monitor the effects. This is a task that cannot be delegated to anyone else. All of these steps that we're going to go over here shortly are essential to safely administer the medications. Medication error You have to be very, very careful when administering the medications because medications have the potential of causing the patient harm. It could be um, a mild effect from the medication, or it could be very, very serious, such as death. So, looking at the evolution of nursing responsibilities regarding medications, the nurses need to collaborate with the physicians and the pharmacists and prepare and participate in that system of checks and balances. And all of this is designed to promote the beneficial effects of the medication and to limit the potential for harm. Correct administration without any additional interventions cannot ensure that the treatment will result in a therapeutic objective. You have to make sure that all the things are in place before you can safely administer the medication. It's more than just giving a patient a pill. And these are things that the nurse must know prior to giving the medication. The nurse needs to know what medications are appropriate for the patient, what medications are contraindicated for the patients. And this could be due to allergies, but it could also be due to other medications the patient may be taking or any other underlying conditions. The nurse needs to know the probable consequences of the interaction between the drug and the patient. What is the medication supposed to do? What are the potential side effects or adverse effects of the medication? The nurse needs to also serve as an advocate. The nurse is always an advocate for the patient. You need to follow the patient's status very carefully, very closely, before, during, and after the medication administration. And pharmacists and prescribers are humans as well as us. So it can be very easy to make a mistake. So another responsibility of the nurse is to make sure we catch those mistakes and prevent harm to the patient. We are the actual first member of the healthcare team to observe and evaluate the medication response and intervene if we need to do so. We need to know the actual response to the medication is supposed to happen. What exactly is this medication supposed to do? If it's an antihypertensive, the medication is supposed to lower the blood pressure. We are the last line of defense for the patient since we are the ones who are actually administering the medication in most facilities. It is ethically and legally unacceptable to administer a medication that is harmful to the patient, even though the medication has been prescribed by a licensed prescriber and dispensed by a licensed pharmacist. So, a physician can write an order for a medication the patient may be allergic to. The pharmacist can fill the order and process the order and have the medication available to the patient. The nurse can administer the medication. The nurse would be legally responsible for giving that medication, and they would also be legally responsible for any reactions that may occur, especially if the nurse knew the patient had an allergy to that medication. So, who would be responsible for that medication error? Well, the prescriber would be responsible if it was a known allergy, the pharmacist would be responsible, and the nurse would be responsible as well. Safe administration is absolutely essential. The nursing process, using your ADPI, provides a framework for the medication administration process. Clinical calculations, there's a reason why we make you guys do math. Clinical calculations, dosage calculations, must be done without error. You must be very cautious with your conversions within and between the metric and the household, the apothecary systems. You've got to be very careful with your calculations. And even pediatric calculations, they're not just small adults. They have their own special requirements. They require particular caution when calculating their dosages. So the things you need to know, the things you must possess to safely administer medication. Well, you need to have some knowledge. You got to know a little bit of everything. You got to know your patient. You got to know the medication. You got to know what the anticipated reaction of the medication. You got to know the potential adverse effects of the medication. You need to have the psychomotor skills, the actual experience on how to administer medication. Keep in mind, it's more than just giving a pill. There's other routes that you need to be familiar with. You got to have a proper attitude to safely administer medication. You got to be disciplined. You need to take your time to ensure no errors occur. You need to be responsible and accountable for that process of administering medication. And you also need to ensure safe nursing practice. So let's look at some multiple choice here. Okay, which types of medication actions um, occur? Okay, you have therapeutic effect, adverse effect, idiosyncratic reaction, side effect, toxic effect, and allergic reaction. Well, for therapeutic effect, that is actually the expected or predicted physiological response. So the correct answer for 1 would be D. For number 2, adverse effect, the correct response would be F, an unpredictable response to a medication. Number 3, idiosyncratic reaction, the correct response would be A, an overreaction or underreaction or different reaction from normal. For example, some people, Benadryl is an antihistamine known to be quite sedating. However, for some people, it does the exact opposite. It makes them hyper. Number 4, side effect. The correct answer is B, unavoidable secondary effect. Number 5, D, toxic effect. The correct answer would be C, accumulation of medication in the bloodstream. Later on in this presentation, we'll learn about how medications are cleared from the body. If medications are not properly cleared from the body, they start to build up, and this can actually create a toxic effect where there's too much medication in the bloodstream. Number 6, allergic reaction. The correct response is G, an unintended, undesirable, often unpredictable response. It could also be F, unpredictable response to a medication. Now keep in mind, allergic reactions are different than adverse effects. Allergic reaction is actually going to involve the inflammatory response system. Looking at pediatric patients, we need to realize that they are continuously growing and developing. There are different age groups, and with the different age groups, there presents different challenges. There have been 2 laws in effect, the Best Pharmaceutical for Children Act in 2002 and the Pediatric Research Equality or Equity Act of 2003. Two-thirds of the medications used in pediatrics have never been tested on pediatric children. And to protect the children, protect our small folk and everything, we have these two laws here. All patients are considered pediatric if they're less than 16 years of age. And remember, pediatric patients, they're going to respond differently to medications than the rest of the population. They're going to be more sensitive to the medications than other patients. They're going to show greater individual variation. They may have some sensitivity issues due to the organ system maturity, and they are going to be at an increased risk for adverse drug reactions. Now, premature infants are usually considered those that are less than 36 weeks of gestational age. Full-term infants, 36 to 40 weeks of gestational age. Our neonates are those itty bitties within the first 4 postnatal weeks. Infants, weeks 5 to 52 postnatal. Your children are going to be considered 1 to 12 years of age, and your adolescents are going to be considered 12 to 16 years of age. You not only got to look at the growth and development, you need to make sure a lot of a lot of pediatric dosages are calculated based on weight. Your pediatric patients, they're going to be vulnerable to the unique adverse effects related to the organ immaturity and that ongoing growth and development. Some examples of age-related effects. Glucocorticoids, such your steroid medications, can actually cause growth suppression, especially in long-term use. Tetracyclines, which is a type of antibiotic, can cause discoloration of developing teeth. And your sulfonamides can actually cause kernicterus, which is brain damage due to untreated jaundice. Your pediatric patient's dosage is often determined based on body surface area, your BSA. And a lot of facilities will actually have charts to help you with those calculations. The initial pediatric dosing is usually an approximation because every individual is different with pediatrics because of their increased sensitivity. Unfortunately, it's let's give it an approximation for this child, see how this dosage works, and then we can adjust it accordingly. Your geriatric patients, they are disproportionately the highest prescription drug users. 12% of Americans are age 65 or older, and this 12% consumes 31% of all prescribed medications. Their geriatric patients experience more adverse drug reactions and drug-drug interactions than younger patients. Geriatric patients are going to be more sensitive to medications than younger adults, and they have a wider variation of how they are going to react. This could be due to they often have comorbidities or multiple severe illnesses, multiple drug therapy. Um, some patients will go to several different physicians, and a physician can order one medication for this, and another physician can order a different medication for the same problem. This can lead to excessive prescribing. Geriatric patients also tend to have poor adherence to their medication treatment regimen. And before you cast judgment on the patients for this, ask your patient, why aren't you taking your medication? A lot of times it could be just because they couldn't afford their medication. Maybe they cannot read the labels clearly. Maybe they do not understand how to take their medications accurately. Individualization of treatment is absolutely essential. Every single patient must be monitored for desired and adverse responses. The regimen must be adhered to, and always consider the goal of the treatment is to reduce the symptoms and improve the quality of life. Usually for our geriatric patients, the cure is impossible. With the geriatric patients, you need to consider their renal function. You're going to look at their creatinine and their BUN when looking at their um, basic metabolic panel, complete metabolic panel, Chem 7, Chem 14, Chem 12. You're going to hear it referred to a lot. But the particular lab values you're looking at are the BUN and the creatinine. Use the creatinine clearance, not just the serum creatinine, because lean muscle mass, which is a source of creatinine, actually declines in parallel with the kidney functions. So your creatinine clearance is actually looking at how well the kidneys are actually filtering out the toxins. Your creatinine levels may be normal even though your kidney functions are greatly reduced. And let's talk about polypharmacy. What is polypharmacy? Is when a patient takes two or more medications to treat the same illness, takes two or more medications from the same chemical class, use two or more medications with the same or similar actions to treat several disorders at the same time, or mixes nutritional supplements or herbal products with medications. Keep in mind, you need to consider over-the-counter medications along with herbal preparations and prescribed. Taking your over-the-counter medications frequently, the lack of knowledge about the medications, incorrect beliefs about medications, and visiting several healthcare providers to treat different illnesses increases their risk for polypharmacy. And here's a prime example of your polypharmacy right here. Now we're going to look at the 6 rights of medication administration, and I've actually added one. To safely administer medication, you need to check all of these items each and every time you give a medication to a patient. You need to do this for each and every medication you administer to a patient. You need to know, is this the right medication, the right patient, the right route, the right dosage, the right time, the right kind of documentation, and the right reason. And I added the right reason, and we'll talk about that here shortly. And this is just a little graphic to tell you about the 6 rights of medication. And you guys can look at that at your leisure. Looking at the right medication. Here are 3 examples of medications: Celebrex, Celexa, and Cerebex. Are they the same medications? No, they're not. Far from it. Celebrex is an anti-inflammatory. It's a non-steroidal anti-inflammatory. Celexa is an antidepressant. Cerebix is an anti-seizure medication. Three completely different medications, three complete different actions of the medications. So how can we prevent from confusing these medications? Well, there is the Tallman lettering system that is in effect right now to kind of help providers and nurses distinguish the different medications. You can see where some of the letters of each medication are capitalized. Again, this is called Tallman lettering. And this is used for your look-alike, sound-alike medications. Another thing that most facilities are doing, and Joint Commission actually strongly recommends, is that they not store these medications in the same location. So if you're using an automated medication dispensing system, one medication will be in one area, next medication will be in a completely different area. They don't store the medications in the same drawer. Your classification, your medications are classified according to the characteristics. They're going to be classified according to the effect of the medications on the body system, the symptoms that the medication relieves, and the medication's desired effects. Your medication forms, it can come as a solid, liquid, other types of oral forms, topical, parenteral, forms for instillation into body cavities. For example, these puppies, they are, I would consider transdermal because you snuggle and cuddle with puppies. So, promoting adherence. First and foremost, you need to educate your patient on their medications. Effective education needs to include their dosage size and the timing of the medication. Tell your patient what their dose should be. How many pills do they need to take? How many tablets do they take? What times of the day should they take this medication? The route and the technique of administration. Is it something they swallow whole? Can they chew it? Do they need to place it under their tongue? The duration of the treatment. How long are they going to be taking this medication? For example, antibiotics are usually given anywhere between 7 to 14 days. You need to make sure you educate your patients that the treatment is going to take this long and to take all of the medication. You also need to teach the patient about drug storage. Does this medication need to be stored at room temperature? Does it need to be stored away from sunlight? Does it need to be refrigerated? You want to teach the patient the nature and the time course of the desired responses. Let's use our antibiotics again. Patient could be taking antibiotics and expect to feel better within 24 to 48 hours. But you also need to educate the patient that they need to continue taking the medication even if they do feel better. Some medications take longer time for it to be effective. You need to teach the patient the nature and the time course of adverse responses. If an adverse response was going to occur, at what time frame would the patient expect for that to happen? Before giving the medication, you need to do an assessment of your patient. Get some baseline data. The things that you are going to need to evaluate to look at their therapeutic responses and adverse effects could be vital signs, lab values, and allergies. You want to identify your high risk patients, your patients with liver or kidney impairment, those with genetic factors that you need to be considered. Drug allergies. Pregnancy. If you're giving medication to an individual who is pregnant, you're not administering that medication to just one patient, you're administering it to two. Look at your elderly and your pediatric patients. The tools you're going to use to help identify these high risk patients is your patient history, your physical examination, and please, please, please do not forget to look at their laboratory results. Some medications have more than one indication. The dosage may differ depending on what the indication of the medication is. Look at aspirin. You'll see aspirin referred to as ASA. There are different dosages for aspirin. There's 81 milligrams, a low dose. There's 325. What is aspirin? Aspirin is a nonsteroidal anti-inflammatory medication, often given for pain and fever reduction. Well, for pain, the typical dose for aspirin is 650. So if your patient is taking aspirin 325 milligrams, are they taking it for pain relief? Or could they be taking it for a different reason? Physicians often prescribe aspirin for cardioprotective reasons. If that's the case, the dosage may be 81 milligrams a day, or it could be 325 milligrams a day. Look at the reason why your patient's taking that medication. Many medications can be administered by more than one route. Kayexalate, for example, is given to patients with high potassium levels. Well, Kayexalate can be given orally, or it could be given rectally through an enema. You need to make sure that the order tells you which route to give the medication. And the dosage may differ depending on the route selected. For example, opioid medications. Morphine. Morphine can be given orally or it can be given parenterally. Well, the parenteral dosage for morphine can be 1 to 2 milligrams. Well, the oral dosage is 2 to 4 milligrams. Make sure you read the medication order carefully. Verify the identity of the patient. Use your patient identifiers, patient's name, date of birth. Read the medication label carefully. Verify the dosage calculation. Implement any special handling that the medication may require. Some medications, especially your chemotherapeutic agents, cannot be handled with your bare hands. Sometimes you need to wear gloves. Nitroglycerin is a medication, it's a cardiac medication. If it touches your skin, it can cause a drop in your blood pressure. You don't want that to happen, so you need to be careful how you handle it. Don't administer any medication if you do not understand the reason for its use. I cannot stress this enough. You will be asked in the clinical facilities prior to giving a medication to tell us, what is this medication for? If you do not know, you're going to be required to look it up. Do not ever, ever, ever give a medication without knowing the reason for the medication, what it does, and any potential adverse effects. So let's take some practice here. Okay. We have acetaminophen, which is the generic name for Tylenol, 10 to 15 milligrams per kilogram PO every 4 to 6 hours PRN for pain. Is this a complete order? What are we missing? Well, one, we're missing the patient's name. We're missing the date that the order was written. But we have the name of the medication. We have a dosage, 10 to 15 milligrams per kilogram. We have the route, PO or per auth. We have a time frame, every 4 to 6 hours. And we have a reason, PRN as needed for pain. Our patient is 8 years old with a sprained knee. He reports pain 2 out of 10. His temperature is currently 101.3 and he weighs 77 pounds. So, he reports a little bit of pain, but would it be appropriate to give him that acetaminophen for that pain level? Well, probably not. We probably want to save the pain medication for a time where he is in pain. Because if we give him the pain medication now, he would not be able to have an additional dose until 4 to 6 hours from now. But look at that temperature. His temperature is 101.3. Well, first instinct would say, oh, well, let's give him some Tylenol to bring that temperature down. But can we do that with this order? No, we cannot. The only indication for the acetaminophen is for pain. It does not refer to elevated temperature, so we cannot give that medication. If we do administer the medication for the temperature, we would be practicing outside our scope, and that is a no-no. All medications have that potential to produce undesired effects. So you need to know these following things. The major adverse effects that a medication could produce. Now, if you look at a medication drug guide, you could see a book on the types of adverse effects that the medication occur. Do we expect you guys to learn all of those? No. But you do need to be familiar with the most common ones. For example, Benadryl. An adverse effect is drowsiness. We know this. Okay? That is a very common, and in fact, it's the most common side effect for the medication. You need to know the time frame when these reactions are expected to occur. You need to know the early signs that the adverse reaction is developing. What are the first hints that something wrong's going on? And what kind of interventions can we do to help minimize that discomfort or that harm? Take a thorough look at the patient's medication history. What medications are they currently taking? What medications have they taken in the past that potentially caused an adverse reaction? Make sure you advise the patient to avoid any over-the-counter medications that can interact with the prescribed medication. Make sure you monitor for the adverse interactions that are known to occur. And be alert for those interactions that could occur that you don't know about yet. Now, what does PRN mean? PRN means pro rata, meaning as needed. The nurse has the discretion regarding on how much medication to give and when to give it in these situations. Make sure you know the reason for the medication use, and you need to be able to assess the medication's needs. Managing toxicity, an early indication makes early intervention possible. Know the signs and symptoms of toxic effects. For example, for digoxin. Digoxin is a cardiac glycoside. It is a medication that lowers patient's heart rate. With a toxic effect of digoxin, the patient may experience halos around objects. Knowing that can give you a better indication of, oh, hmm, patient seeing halos. Well, maybe I need to check for the digoxin levels in the medication in the patient's blood levels. Know what to do in cases for toxicity management. Well, first step is to stop giving the medication. Make sure you notify the physician. When teaching about the dosage and administration, make sure you give the patient this following information: the name of the medication, the dosage and the schedule of administration, how to administer the medication, how long the medication is going to be used, and how to store the medication. You want to promote the therapeutic effects of the medication. You need to understand the nature and the time course of the expected benefits. Recognize if the treatment fails. Allow for timely alternate therapy implementation. For example, if a patient has high blood pressure and you give them a blood pressure medication to lower it, understand when should I expect to see this medication to take effect? What do I do if the medication was not effective? You want to minimize the adverse effects. Be careful with insulin administration. Your anti-cancer and infection, um, your chemotherapeutic agents lowers the patient's immune system. Well, in doing so, that makes the patients more prone to infections. Some side effects, even though they're benign, they can be very disturbing, especially if they're not known to the patient. So if you expect a medication to cause itching, make sure you let the patient know that. Make sure you educate the patient about any kind of hazardous drug or drug food interactions. For example, phenelzine. That is an MAOI inhibitor, a monoaminoase oxidase inhibitor. I think that's what it is. Anyways, you cannot give phenylphene with any kind of amphetamines or figs. Okay? It can cause very dangerous reactions. Your additional, we everybody's familiar with the oral administration of medications, but here are some additional routes. You have your topical, your transdermal, inhaled, rectal, vaginal, and sometimes you even have direct injection to a specific site. Hearts, joints, nerves, central nervous system. Nurses don't usually do those, but you need to be familiar with them. Your medication interactions occur when one medication modifies the action of another. A synergistic effect occurs when the combined effect of two medications is greater than the effect of the medication given separately. This You see this with your combination medications, such as your Maxide. Maxide has hydrochlor. Oh, I can't remember what it is. But anyways, it's two medications and they combine together to create a synergistic effect of increased blood pressure control. the horrors of medication. And looking at the oral routes again. You have your oral. Your sublingual is going to be underneath the tongue. Buccal is going to be against the cheek membrane. Topical can either be directly onto the skin, or it could be in a body cavity, such as vaginal or rectally. You have inhalation medications. In acute care facilities, respiratory therapy assistants usually administer the inhalation medications, but that doesn't mean you don't need to know how to do that. Your parenteral medications, this can include your intradermal, your subcutaneous, your intramuscular, and your intravenous. There are other routes of parenteral, such as epidural, intrathecal, interosseous, intraperitoneal, intrapleural, intraarterial. We don't usually do those. Intraocular is into the eye. Now, our systems of medication and measurement. We've got to be able to compute the dosages accurately and in a timely manner to make sure the medications are administered correctly. Most medications use the metric systems, but some still use household systems. Okay? Make sure when using the metric system, you put a 0 before the decimal point only. And if you have any questions about that, look at your dosage calculation rounding rules. Metric system is more commonly used because it's logically organized. It's based on factors of 10. You have meters, liters, grams, kilograms, and so forth. Your household system, that's what's going to be most familiar to your individual patients. The disadvantage with it is that it's often very inaccurate. So looking at the metric specifics, our abbreviation for gram is G or GM. I prefer you guys to use G. Liters is going to be your L. Use lowercase letters for abbreviations for other units. For example, look at milliliter, lowercase m and a large case L. You want to convert your fractions to decimals. So if you're talking about a half a gram, you're talking actually about 500 milligrams or 0.5 grams, not 1/2. When it comes to medication errors, make sure you report all medication errors, whether it occurred from the prescriber's role, if pharmacist's role, to your role. And the reason for reporting errors is not for punitive measures. It's not for somebody to get punished, get put in timeout in the corner. The purpose of reporting medication errors is to ensure to discover where in the process the error occurred and assure that that error does not happen again. Patient safety is always going to be top priority. You want to do documentation of the medication error. Don't document it in the patient's chart, but follow your facility's policy and procedure. The nurse is responsible for preparing a written occurrence or an incident report. You want just to state the facts, no opinions or anything like that. Just a factual description of what happened and what was done. And again, nurses, we're the last line of defense before the medication reaches the patient. We play an absolute essential role in medication reconciliation. Quick quiz. If a nurse experiences a problem reading a physician's medication order, the most appropriate action would be to A. Call the physician to verify the order. B. Call the pharmacist to verify the order. C. Consult with other nursing staff to verify.
Or D, withhold the medication until the physician makes rounds. Correct response is A, call the physician to verify the order. I have even taken a copy of the physician's orders to another unit to track the physician down to say, what did you write here? You want to make sure you can read the physician's order. If you can't read it, there's going to be a medication error. So, keys to accurately administer medication. You want to avoid distractions and follow the same routine. So, if you're in the medication room and you're preparing a patient's medications and your coworker wants to strike up a conversation about what they did last night, you need to tell your coworker, hey, look, I need to concentrate. Now's not a good time. Let's talk about it during lunch. Administer only the medication you prepare. Never leave your prepared medications unattended. So, another nurse is preparing medications and they get called to another patient's room and they hand you their medications and say, hey, can you give this to the patient in room 205? Would you administer the medications? No. You didn't prepare the medications. You don't know what you're giving. You don't know that patient. So it's not going to be safe to do that. You want to document your medication administration immediately after administering the meds. Use your clinical judgment in determining the best time to administer PRN medications. If a patient gets a medication every 4 to 6 hours and it's only been 2 hours since they've had the last dose, it's not a good time to give them their next dose. When preparing medications, make sure you compare the medication container label against the medication administration record at least 3 times. These are going to be your 3 checks. All of these are going to help reduce the medication errors. You want to make sure you maintain your patient's rights. Their rights include they have the right to be informed about a medication, to refuse a medication, to have a medication history, a history of what medications they've taken and when, to be properly advised about experimental nature of medications, to receive labeled medications safely, to receive appropriate supportive therapy, to not receive unnecessary medications, and to be informed if any medications they're receiving are a part of a research study. So let's apply the nursing process, your ADPI, in the medication administration. Well, the first thing you're going to do is assess. Do your pre-administration assessment. Then you're going to do your nursing diagnosis, your planning, implementation, and evaluation. As part of your assessment, you're going to look at their medical history, any allergies, medications they're currently taking, their diet history. Are they adhering to the medication therapy? Why or why not? What's the patient's perception about the problems that they have? What is the patient's current condition? What's the patient's attitude about medication use? Are they okay with taking medication or are they staunch rejectors of medication? Assess the patient's understanding and adherence to the medication therapy. If they don't adhere to their medication therapy, ask them why. And understand the patient's learning needs. Do they know their medications? Do they not know their medications? Do they take medications they don't know what they're for? Look at the patient's vital signs. Make sure you check their lab values. These are some nursing diagnosis labels that apply to medication administration: anxiety, ineffective health maintenance, readiness for enhanced immunization status, knowledge deficit. There's always something to teach. Non-compliance, I don't like that one because it has such a negative connotation to it. But if the patient's not taking their medications, you could use non-compliance as a nursing diagnosis. But again, research the why. Impaired swallowing or effective therapeutic regimen management. Looking at the planning. Always make sure you organize your care activities to ensure the safe administration of medications. If you're in the middle of a dressing change, now's not the time to do medications. Make sure you set goals and related outcomes that are going to contribute to the patient's safety and allow for the wise use of time during medication administration. When's the best time to teach a patient about medication? How about when you're actually administering the medication? Make sure you provide the most important information about the medications first. Okay? Don't tell the patient that this medication may cause diarrhea. Oh, and by the way, this is your antibiotic for your infection. Tell them that this is your antibiotic. This is used to treat your infection. One of the more common side effects is diarrhea. This is how we can treat the diarrhea, how you can manage it. When the patient's being discharged, make sure the patients know where and how to obtain the medications. And this is commonly a job for case management. Sometimes patients are administered medications in the hospital that their insurance doesn't normally cover. So a good case manager would be on top of that and have additional resources available for the patient to be able to acquire their medication. Looking at implementation, you have acute care, restorative care, and your special considerations. With acute care, this includes the receiving, transcribing, and communication of medication orders. You want to make sure you have accurate dosage calculation and measurement of the medications. You want to safely and correctly administer the medications and accurately record the medication administration. Always consider the special ones, the special considerations for your infants and children, especially with their dosing, and think about the psychological prep when administering medications to children. If you're coming at the child with a needle, you may want to prepare them somehow. Make sure you take a look at the elderly. Paying close attention to their laboratory values, their vital signs, and are they under any kind of polypharmacy? If they're taking multiple medications for the same condition, maybe that's something you need to notify the physician about so they can maybe do some adjustments. And documentation. Documentation is always um, something that you need to improve, but I cannot stress how important accuracy is with medication administration documentation. With a physician's orders, these are the elements that must be there for it to be a complete order. You must have a date, time, medication, dosage, route, frequency, and the reason, especially if it's a PRN medication. Let's look at these orders right here. Lisinopril, which is an ACE inhibitor, an angiotensin converting enzyme inhibitor. That should sound a little bit familiar. Lisinopril 20 milligrams BID. Is that a complete order? If not, what's missing? Well, what's missing is we don't know the route. And BID is one of those abbreviations Joint Commission recommends you don't use because it can be very easily confused. They actually recommend that you write it out twice daily. Look at the next one, verapamil, 80 milligrams, 80, excuse me, verapamil, 80 PO, 3 a day. Is that a complete order? No, it's missing several elements. Well, first thing, it's missing what unit of measurement? Are we talking 80 pills, 80 milligrams, 80 grams, 80 teaspoons? How much verapamil are we supposed to give to a patient? 80 milligrams PO, 3 a day. Okay? 3 a day, we want to write it out 3 times daily. 3 a day could be 80, 83, 80. How much? Looking at the next one, a Presaline, IM, PRN. What's missing there? Well, how much of Presaline are we giving? Well, we're going to give them 10 milligrams. How often do we give it to them? Good question. Every 8 hours, PRN. And we need a reason for giving this Presaline. Okay, we give it a PRN. Is this for pain? Is this for blood pressure? Is this for an MRI? Why are we giving it? Well, in this particular case, we're giving it for systolic blood pressure greater than 180 or diastolic blood pressure greater than 100. Look at the next one, colchicine, 0.6 milligrams PO daily. Is that a complete order? Actually, it is a complete order. This one's not too bad. Okay, so make sure when you're looking at a physician's order, it's a complete order. If something is missing, you need to notify the physician to get a clarification. Your MAR, your medication administration record, you have to look at the physician's order every single time. Yes, you do. Okay? How do I know what the last person gave? Well, you look at your MAR. The last person should have documented the time and the route that the medication was given last time. How can I show what I gave? Well, you're going to do the documentation on the MAR. What if the patient refused the medication? What do I do? Well, you would also document that on the MAR as well. In lab, we will actually play with an MAR and we'll look at a blank one. We'll look at one with the medications transcribed, and you will have an opportunity to actually document on the MAR as well. Looking at implementation for your health promotion, teach the patient and the family, if the patient consents, the benefit of the medication, how to take the medication correctly, the symptoms of any adverse effects or side effects, and the safe use of the storage of medications. Help the patient establish that medication routine. So if it's a medication that's to be given once a day, have the patient take it every morning with their breakfast. Refer them to community resources for transportation if they need to. If they're getting weekly intravenous infusions, make sure they have transportation to go to the clinic to get that done. Always value the patient's participation in evaluation. Remember, care plans, nursing process, you need to collaborate with your patient. Ensure that make sure the patient understands the medication schedules and are able to safely administer their medications. If the patient has severe osteoarthritis in their hands, They may not have the dexterity to give themselves injections. So that's something that you want to assess prior to discharge. Educate your patients to be alert for reactions taking several medications, and you need to be alert for the potential reactions in patients with several meds. Evaluate the patient's responses. Use your physiological measures. Look at their vital signs. Look at their lab values. Look at their behavioral responses. Are they calm? Are they getting agitated? Are they angry? Rating scales. What do we use rating scales for? Well, we use a rating scale when we're assessing pain. So if we're giving a pain medication, we ask them on a 0 to 10, what level is your pain right now? 0 being no pain, 10 being the worst. And utilize your patient's statements. So, how are you feeling right now? Well, I'm feeling pretty good after you gave me that pain pill. Okay? All right. Use that patient's statement to evaluate the effectiveness of the pain medication. Oral administration is the easiest and most desirable route, except when you're giving it to animals. Animals do not like pills for some reason. Keep in mind with oral administration of medications, food may decrease the therapeutic effect and actually may increase the therapeutic effect. So you need to know whether or not to give the medication with food. Be aware of aspiration precautions. You want to assess your patient's ability to swallow. If they cannot swallow effectively, they're going to be at higher risk for aspiration. Patients that are given tube feeds in enteral or small bore feedings, you want to make sure you verify that tube's location and make sure it's comparable to the medication absorption. You want to follow the American Society for Parenteral Enteral Nutrition guidelines. Liquids are going to be best when using enteral feedings. If medication is to be given on an empty stomach, you're going to need to stop the tube feedings at least 30 minutes before and after feeding. And with enteral tube feeds, the risk of drug-drug interaction is actually going to be higher, something to consider. When applying topical medications, unless you want the effect of the medication too, you need to wear gloves. Okay? If it's wet and not yours, don't touch it. Use sterile technique if the patient has an open wound. You want to make sure you clean the skin first. Okay? If they've had the medication before, you want to clean that area before applying a new dose, or you may actually cause toxic effects. Follow the directions for each type of medication. For your transdermal patches, make sure you take off the old patch before putting the new one on. Educate your patients of this also. You want to document the location of the new patch. Some patches you keep in the same area, some patches you put in a new area. Be familiar with that. Ask about patches during the medication history. It's very easy to lose a patch on a patient. So you ask the patient, hey, do you still have this patch on? Apply a label to the patch if it's difficult to see. Some transdermal patches are clear. And that is designed for aesthetic purposes for the patient. However, when you're trying to look for it, it does make it very difficult to see. And document the removal of the patch as well. Some medication transdermal patches require them to be applied for 12 hours on, 12 hours off, so you need to document when you actually remove the patch. I actually recommend you write your initials, date, and time on the patch when you apply it. It's just a little added precaution there. And here's an example of some pictures, some do's and don'ts with transdermal medication administrations. You do want to make sure you clean the areas from the old patch. Don't Forget to remove the old patches, document, place and time, and you want to put the patch over dry skin. You don't want to put the patch in area of heavy, dense hair. Don't shave the don't shave the hair because that can create an open wound and lead to direct application of the medication, and that could actually cause harm. Don't place heat over patches, such as taking a hot bath or place over areas of inflammation. With patches, some patches you may need to remove before the patient gets an MRI or a CT scan. Also, be familiar with that. This right here is an example of a nasal installation of medications. Depending on the medication and where exactly it needs to be administered. For example, this medication right here is the goal is to be administered in the ethmoid sinuses or in the sinus cavities. Be familiar with the positioning in which sinus cavity you need to put it in. With eye medications, you want to avoid applying the medication directly onto the cornea. Avoid eyelids with the droppers or the tubes to decrease the risk of infection. Don't touch the top of the dropper or the medication tube to the eye. Only use on the affected eye. Okay, if a patient has an infection in one eye, don't let the patient talk you into, oh, go ahead and put some in the other eye too. Nope, don't do that. And never, never, never allow a patient to use another patient's eye medication. That's just, you just don't do that. Just don't do that. Your intraocular installation, it's a disc. Looks very, very similar to a contact lens. You need to make sure you teach the patient how to insert and remove that disc and teach them about the potential adverse effects also. For your inner installation, keep in mind that those structures, those inner ear structures, are very sensitive to temperature, so you want to make sure you store the eardrops at room temperature. Giving them too cold can actually cause the patient to experience some vertigo, dizziness, nausea, just not good. Make sure you use sterile solutions, especially if the eardrum is ruptured. Any kind of drainage from the ear at this point could indicate that the eardrum has ruptured, so you want to make sure you pay uh, special care. Never occlude the ear canal. Okay. Um, Forcing the medication into an occluded ear canal could actually cause some pressure injuries and can further injure the eardrum. And then don't force the medication into an occluded ear canal. This is some demonstration on how to administer vaginal medications on rectal installation. And when giving suppositories through the rectum, make sure the suppository is up against the membrane of the intestine, not in the feces. Okay, you want it to be able to hit that mucous membrane so it can absorb and do its job. Your inhalation medications could be aerosol spray, mist, powder through handheld inhaler, often used for either respiratory rescue or maintenance. You have your MDIs. Keep in mind that your patient still needs to have that hand dexterity, the hand strength to be able to use those MDIs. Your breath actuated MDIs, those release depends on the strength of the patient's breath. So if the patient doesn't have good inhalation breath, then they're not going to be able to adequately get that medication in. Your dry powder inhalers are also activated by the patient's breath. Again, they need to have the dexterity, they need to have the coordination to be able and the strength to take that deep breath in. Your inhalation medications produce, the goal is to produce the local effects, such as bronchodilation. You see these given with asthma patients or patients with COPD. Also, keep in mind that even though it's an inhalation and most of the time it's going to create local effect, it could also cause some serious systemic effects as well. And here's another little picture for you guys that you guys can look at the differences between the MDIs, the dry powder, and a nebulizer. With irrigation, usually is used with sterile water, sterile saline, or antiseptic solutions in the eye, ear, throat, vagina, or urinary tract. If there is a break in the skin or the mucosa, you want to make sure you use sterile aseptic technique. If the cavity is not sterile, you can use clean technique, such as in the ear canal. For parenteral, that's going to be an injection into the body tissues. This is an invasive procedure and requires aseptic technique. Anytime you invade the patient's body, you're going to increase their risk of infection. You need to have certain skills to do for each type of injection. This route of medication administration, the effects are going to happen very rapidly, and it's going to be, and that's going to depend on the rate of the medication absorption. We're going to look at the syringes and the different aspects of each syringe. You have your Lurlock, which is what's most commonly used in healthcare facilities now, where it's kind of a screw on top. You have your non-Lurlock. You don't see these used as often, but they are still out there. Your syringes can vary in size, anywhere from 0.5 milliliters to a 60 ml syringe. Your larger sizes are usually used to give IV medications and to irrigate wounds or drainage tubes. You actually saw a 60 ml syringe when doing your NG tube insertions. It may come prepackaged with the needle, or you may need to attach the needle separately or change the needle out. And these are the different types of syringes. The one, syringe A is a Lurlock syringe, 5 mLs. B is a 3 ml. C is actually a tuberculin syringe. Those are usually used for your intradermal injections, sometimes subcutaneous. And then D is an insulin syringe where the calibration is actually in units rather than milliliters. Notice that the tuberculin syringe, it only holds 1 ml of solution. Here you have the different parts of your syringe. The tip is to remain sterile at all times. That's what's going to attach to the needle. You have the barrel of the syringe, and you see that little black part that looks like a little triangle. When doing your measurements inside the syringe, when you measure how much medication you're drawing into the syringe, you want to measure it to that tip of that black section right there. Okay? And then you have the plunger. Okay? And if you look at the second syringe, it actually tells you where to measure the dose and to avoid touching the end of the plunger, because remember, that's going inside the barrel of the syringe. You want that to stay as clean, as sterile as possible. This is the parts of the needle. The angled end is called the bevel. Depending on the the method of administration, you want the bevel up or down. The length of the needle is called the shaft. And if you look at the color of the hub of the needle, that can give you an indication of the size. Needles are measured in gauges. Um, the higher the number, the smaller the size of the needle. So for a 25 gauge needle, that's a pretty small diameter needle. A 16 gauge needle, that's going to be your garden hose. That's going to be a very large diameter needle. And these are some examples right here. When looking at your needles, also consider the length of your needles as well. This right here is called, you'll hear it called as a tube eggs or a Carboject. These are disposable injection units where the medication actually comes into um, a very slim disposable vial that you can actually load into the Carboject. They're not used very often. Um, you still see them on occasion and everything. But if you don't have a Carboject syringe unit and everything, you can still draw the medication up using a needle and syringe. If you look at picture A, these are vials, or excuse me, these are ampules. These are glass ampules. And to withdraw the medication from these ampules, you need to use a filter needle. There is a special way to open these to avoid injury. Remember, these are glass, and it is not fun if you get that piece of glass in your fingers. So there is a safe way to open these, and you must use a filter needle to withdraw the medication. You don't want glass particles in the medication before you administer it to the patient. After you withdraw the medication with your filter needle, you're then going to change the needle out to a regular needle before administering it to the patient. The items that are in picture B, those are vials. You don't have to worry about glass entering the medication, so you can use a regular needle when withdrawing the medications from these. If two medications are compatible, you can actually mix the medications if the total dose is within the accepted limits. Now, the dose of the amount of medication that you can give in an injection is going to really depend on the size, and we'll talk about that here shortly. Okay? But the advantage of mixing the medication is that the patient only gets stuck once instead of multiple times. But you have to be very, very careful on making sure that those medications are going to be compatible with each other. When mixing medications from a vial and an ampule, you want to prepare the medications from the vial first. You're going to then use the same syringe and a filter needle to get the medication from the ampule. Next, we're going to look at mixing medications from two vials. What you're going to do first is inject air into your first vial, and then you're going to remove the needle from that vial and inject air into your second vial. Once you've injected the air into the second vial, then you're going to flip it upside down and withdraw the solution from the second vial. Then you're going to remove that needle from that second vial, insert the needle back into the first vial, and withdraw the medication. You guys will have opportunities to practice with this. Each injection route is going to differ based on the type of tissues that the medication enters. Before you inject, you need to know the volume of the medication you need to administer, the characteristics and the viscosity of the medication, how thick the medication is, and the location of anatomical structures underlying the injection site. It's not just sticking a patient. You got to know a lot of stuff when doing it. If you don't give the injections correctly, your patient may have some negative outcomes. Some methods to minimize the patient's discomfort. It's no fun getting a shot. Okay, so there are some things that we can do to make it a little bit better for our patients. We want to make sure we use a very sharp beveled needle in the smallest suitable length and gauge possible. Okay, so if we can get away with using a 25 gauge half-inch needle to give the medication, let's do that. Let's not get the 16 gauge 2-inch needle instead. You want to make sure you're selecting the proper injection site using the anatomical landmarks. We'll go over that here shortly. If appropriate and if the physician has allowed this and ordered this, you can use either a vapocoolant spray or a topical anesthetic to the injection site before giving the medication if possible. This is commonly used with pediatric patients. Divert the patient's attention from the question through conversation. Use an open-ended question. Ask the patient what they think about the weather, what they're watching on TV. Okay? Talk about stuff. There is a video out there that I've seen on Facebook, of all places, of a physician giving injection to children. And his method is absolutely marvelous. He uses all sorts of distracting methods to engage the child's attention to where they don't concentrate on, oh my gosh, they're getting a shot. Okay, it's absolutely very, very, very good. You want to insert the needle very quickly and smoothly to minimize tissue pooling. Don't delay it. You want to stab them like a dart. Hold the syringe steady while the needle remains in the tissue and inject the medication very slowly and steadily. Okay? Uh, when giving an injection, let's go back to the sharp beveled needle. Okay? If you use a needle to withdraw medication from multiple vials, say you're mixing medications, what do you think the tip of that needle is going to be like? Do you think it's going to be sharp or do you think it's going to be dull? Well, it might be dull because you've actually stabbed it a few times into vials. So it would be less discomfort for the patient if you switch that needle out to a brand fresh new one, so it gives a sharper edge and it's a little bit better for your patient. Looking at subcutaneous injections, this medication is placed in that loose connective tissue just under the dermis. Remember when we talked about tissue integrity, we talked about the layers of the skin. Well, that subcutaneous injection is going to go just below that dermis. The absorption is going to be lower than with intramuscular injections because there's not as much blood flow to that area as it is with muscle. When giving medications such as low molecular weight heparins, any kind of blood thinner that requires special considerations, you want to make sure you avoid any kind of visible blood vessels, any areas of bruising, scar tissue, those kind of things. You want to avoid those areas anyways whenever you're giving an injection. But with the blood thinners, you want to make sure you do it very precisely. You want to make sure you don't rub the area afterwards because you can cause additional bruising. A patient's body weight is going to indicate the depth of a subcutaneous layer. If you have a very thin, frail patient, their subcutaneous layer is not going to be as thick as your fluffier patients. So your needle length is actually going to be based on the patient's size and the estimated amount of their subcutaneous tissue. Also the angle of insertion as well. Angle of insertion for your subcutaneous is going to be anywhere between 45 degrees to 90 degrees. These are some locations where subcutaneous injections are given. Notice the scapula area, the back area. That's not very commonly used because most patients don't have a lot of subcutaneous tissue in that area, so that's not really my preferred area to use, but it is possible. If you look at the frontal view of the patient, you can look at the back, you can use the back of the arms, you can use the love handles of the patient, the subcutaneous sections of the leg, and the abdomen, of course. Okay, you want to avoid the belly button area. You want to avoid visible blood vessels. You want to avoid scar tissue, stretch marks, those kind of things. All right, looking at your angles of insertions for injections, the first one is a 90 degrees, which is acceptable for your intramuscular injections. It's also acceptable for your subcutaneous injections of those larger patients. Some manufacturers of medication, especially if it's a pre-filled syringe, actually recommend doing a 90 degree versus 45 degree. You're going to use your nursing judgment for that. The second one is actually a 45-degree angle, which is also used for your subcutaneous. Let's look at the last one. The last one is a 15 degree, anywhere between 5 and 15 degrees, and that's going to be used for your intradermal injections. Your intradermal injections are often used for your PPDs, like you guys had to have before coming into the program. It's also used for allergy testing as well. Very, very shallow is going just underneath that first layer of skin. Your intramuscular injections are going to be faster absorption than your subcutaneous route because it has much more blood flow. Many risks are involved with intramuscular, so you've got to make sure you are verifying the location of your intramuscular injection. Your needle length is going to be depending on the size of your patient and also using the location of the injection as well. So, for example, if you have a very fluffy person, a very obese person, a 3-inch needle may be appropriate, whereas your very thin individuals, a half an inch to a 1-inch needle may be appropriate. I have actually given a intramuscular injection into the deltoid of a very, very thin, frail, elderly patient using a 5/8 length needle. Okay, so the length of the needle is going to be based on the size of your patient and the location. The amount of medication that you can administer into intramuscular can be anywhere between 2 to 5 mLs for the adult. For your children, older adults, and thin patients, it's going to be up to 2 mLs. Your little folk, your small children, older infants, up to 1 ml, and then your smaller infants are going to be up to 0.5 mLs. This is important to know. So if you have 10 mLs of medication to give to an adult, you need to either look into possibly giving the medication intravenously or explore the chances that you're going to have to give them 2 injections. Make sure you assess the patient's muscle before giving the injection. Always, always, always properly identify the site by palpating the bony landmarks. Those landmarks are going to help you locate the actual areas where the injection can be given. Be aware of any potential complications with each site. The site needs to be free of tenderness. If they've had an injection in that site, you need to pick a different site. Make sure you do all those steps to minimize the discomfort. And for intramuscular, it's always going to be at a 90 degrees. Okay. To identify your ventral gluteal muscle, and you guys will have opportunity to practice this in lab. The first thing you're going to do is, if you're looking at the patient's right side, you're going to use your left hand to identify the site. If you're looking at the patient's left side, you're going to use your right hand to identify the site. The best way to do it is to have the patient either lying on their back or lying on their side. It's much easier with them lying on their side. You're going to place the palm of your hand over the greater trochanter. In order to locate the greater trochanter, the best way to do that is to have the patient abduct and adduct their leg. Some patients are not going to be able to do this, and that's okay. But you're going to locate the greater trochanter, put the palm of your hand on the greater trochanter. You're going to point your first finger to the top of the iliac crest, the anterior superior iliac spine, and you're going to separate your first finger and your second middle finger, and you're going to create a V. Your thumb is going to be pointing toward the patient's groin. Between your first and your second finger and that V, the ventral gluteal is going to be located right in between there. That's where you give the injection. This takes practice. Practice, practice, practice. Okay? All right. There we go for the ventral gluteal. Okay? For your vastus lateralis, the easiest way to locate this is to put the palm of your hand above the patella. You're going to put the palm of one hand above the patella, the palm of your other hand on the greater trochanter. And that vastus lateralis is going to be moving from the frontal portion of the patient's knee to the lateral anterior side of the patient's hip. Okay, kind of moves at an angle. So your vastus lateralis location is palm of hand above the knee, palm of hand on the greater trochanter. Spread your thumb and your first finger, and in the middle, right there, is your vastus lateralis. For your deltoid injection, the first thing you're going to do is to locate the acromion process. Once you located your acromion process, it's 2 to 3 finger widths down, depending on how the size of your fingers are and the size of your patient. You're going to imagine a triangle. That deltoid muscle is actually a triangular shaped muscle. So for your deltoid injection, imagine that triangle, and X marks the spot. It's going to be right in the center of that muscle. For your Z-track, Z-track's a little bit tricky, but it's actually a good method in giving injections. The purpose of the Z-track is to create a track to where the medication actually stays in the muscle and doesn't seep back up through the path that you created by the needle. So in order to do this, you're going to take the side of your hand and you're going to shift it sideways and up to kind of move the skin around, then give the injection, and after the medication is in, you're going to withdraw the needle and then release your hand. Using that method, the subcutaneous tissue in the skin is actually going to cover up the injection path in the muscle, actually keeping the medication in the muscle. One thing I want to include about IM injections is follow your facility's policy and procedure when it comes to aspiration. Old school methods said to aspirate with your intramuscular injections to make sure that you're not in a blood vessel and everything. But evidence-based practice has shown that It's not really an accurate indicator of whether or not you're in the muscle. In order to actually get blood flow, you have to aspirate for 10 to 15 minutes, and who has time for that? And that just creates further discomfort for the patient. So, they're actually recommending that you do not need to aspirate. But again, follow your facility policy and procedure. Some facility says yes, aspirate. It's no benefit from aspirating, but it does not cause any harm to the patient either. So just follow your facility's policy procedure when it comes to aspiration. For validation purposes, if you do it, great. If you don't, that's fine too. For subcutaneous injections, though, you do not aspirate ever. Same goes for intradermal. Intradermal, you do not aspirate. Again, your intradermals are going to be used for skin testing, usually for your PPDs to test for TB or your allergy testing. It's very, very slow absorption from the dermis. The skin testing actually requires the nurse to be able to see the injection site for changes. That's why they give it to you in your arm. Okay, you're going to use a very, very small hypodermic syringe or a tuberculin syringe. The angle of insertion is going to be 5 to 15 degrees, and the bevel needs to be up. When you are actually inserting the needle, you can, depending on the patient's skin, I know for my skin, because I'm glow in the dark, you can actually see the bevel of the needle through the skin. For your darker skinned individuals, you may not be able to see it, but just picture that bevel's just there, it's just right there. So you want the bevel up. You're going to slowly inject the medication, and you should see a bleb. You should see a bleb or a well as you inject it. If you did not see a bleb, or if a bleb did not form when you inserted the medication, you probably didn't do it right, and your results are not going to be accurate. Safety, safety, safety. Safety is so important when handling needles. 600,000 to 1 million accidental needle sticks and sharp injuries happen annually in the healthcare field, and those are just reported ones, guys. They're very, very common, especially when workers recap the needles. Okay, that is one of my pet peeves: is do not ever recap a needle after it's been anywhere near a patient. If you do need to recap the needle, there is a method to do it safely. You would set the cap down on your surface, and then you're going to scoop the needle into the cap, and then you may secure it once that needle is safely inside the cap. Needle stick injuries also happen with mishandled IV lines, needles left at the patient's bedside. If you left a sharp, you need to dispose of your sharp. Okay. Um, Exposure to bloodborne pathogens are no fun, and they can actually be potentially deadly. Most of your needle stick injuries are preventable. The Needle Stick Safety and Prevention Act actually mandates the use of special needle safety devices to reduce the frequency of needle stick injuries. So most of your facilities are going to use the safety needles. If you have a facility that's not using your safety needles, you may want to talk um, to their OSHA people and see what's going on with that. This right here is an example of a safety device where the needle is actually covered up by a plastic sheath that's covering up um, the barrel of the syringe. Properly dispose of your sharps. Don't stick your hand inside the sharps box to try to get it to get in there. If your sharps box is full, you notify the appropriate person to change out the sharps box. Don't force your sharps inside there. Okay? If it's full, find somewhere else. It is not worth an injury. And that is concluding our medication administration. Please review this video as many times as you possibly can. I will work on an ADA appropriate PowerPoint for you guys for availability. But again, I also will give you guys opportunity sometime this week to present questions.